Hey, I'm Beth McCord. I am a family nurse practitioner. I'm also a SANE, sexual assault nurse examiner, and I am certified in adult and adolescents. I am the operations manager of the Bridge, which is a component of the Center for Violence Prevention, where we do forensic medical exams. We are right now in our exam room, and this is where patients come to get a forensic medical exam, which can include the evidence collection kit. They're able to receive HIV testing, syphilis testing, pregnancy testing, and treatment prophylactically for sexually transmitted infections. We have been very successful in getting DNA off of our kits, and as well as serving the community for these victims. Today I'm going to talk about how to identify victims of trafficking, possibly some red flags that you may see in the clinic or the ER setting. The first thing we'll talk about is chief complaints. What are you going to see the most? And a lot of times with these victims, they'll have unknown pregnancies or miscarriages. They're going to have multiple STIs over a period of time. Multiple visits for pelvic infections. That's the patient who has pelvic inflammatory disease a lot, bacterial vaginosis a lot. The other thing that we know as a component of the human trafficking is overdoses and addiction. So that's something, mostly those would come into the ER as overdosing, or, somebody that you see frequently for pain meds. Sometimes that's just an addiction, but when you have that paired with other things, that should be a red flag. And then if they're malnourished, that's something that we see a lot. If you see malnourished symptoms, or you see ligature marks on their wrists, on their ankles, that's why head to toe is so important. So how do we care for these people? And you got to do trauma-informed care. That's the most important thing. Trauma-informed care is the non-judgmental care that we give. There is patient-centered, and it prioritizes their physical, psychological, and emotional safety for everybody involved. And that's not just the patient, but it's also the staff. So you have to be thinking about all those when you develop your policy and your procedure for these patients. The goal of the clinical encounter is not to get them to disclose. It's not to be their superhero and rush in and save them. The clinical encounter is to treat them, educate them, and empower them. A lot of times they're going to come to healthcare, they're going to feel safer here than they do with law enforcement. So when they come for healthcare, they know they're going to be taken care of. They know you have to take care of them. And so we don't want to sever that relationship over them not doing what we want them to, and that's disclose. So to care for them, we've also got to develop a multidisciplinary team. And that's something where we're at our clinic, we're at our hospital, but we know who our community partners are. We know who the Center for Violence Prevention is. We know what services they offer. We know our law enforcement. We work closely with them. Our therapists, resources that our patients are going to need, we need to make sure as healthcare providers that we know those, and we are able to give those resources to our patients. When you are in your clinic or in your hospital, you got to determine if you're going to assess all patients for human trafficking, or if you're just going to do the ones who identify as high risk. So that's your first thing you've got to do. Most of the time in a clinic or an ER setting, you have to ask those questions. Do you feel safe at home? Is anybody at home hurting you? So this may be where we can interject a couple of other questions that may say, do you know how much you make at your job? Or do you get to keep your ID? Do you get to choose what work you do, or do you get to choose where you live? Just you've got to come up with a couple of questions that would help you to better identify. The most important thing when you're doing those questions is you got to do those when they're alone, as you're supposed to be doing with the other questions. Because if you ask somebody if they feel safe at home, or if anybody's hurting them and their abuser's sitting right beside them, their answer is going to be no. So I go into, and all these steps are important, and I know I've already said that a couple of times, but is to get them by themselves, to interview them alone. If you can do that, is the best way, because that's when you're going to get the most honest questions. How do you get them alone? If somebody's with them, or it's a child, or what have you, I sometimes get creative and say, hey, can you go get their list of meds? You know, they'll bring up, we'll start talking about list of meds, and it'll be in their car, and that person will leave, and I'll use that time to say, hey, I'd like to ask you a couple of questions. Can you answer them honestly with that person in the room, or do we need to get them out? And so that's helpful when you know that piece of information. Sometimes you can kind of gauge if they don't answer questions before looking at the person that's with them. That would tell you, hey, I might need to get them by themselves. I got to get creative so that I can talk to them. I've even said before, it's our policy to talk to the patient by themselves. Anything that you need to do, because ultimately that patient safety is the most important. Now, on the other side of that, when you're talking about patient safety, it might be safer to have that person stay in the room. So nothing is black and white in a policy and a procedure. You got to gauge every situation as it comes, because you may be creating more danger and more harm by separating those people than you are leaving them in the room. So, interviewing them alone, the first thing you got to do is you got to build a rapport, and that's going to happen in the first few seconds of that encounter. When I go into a room, I lock eyes with that patient, and I never take them off until they know exactly why I'm there and what I'm there to do. We also know that it's going to happen very quick, and if it doesn't, sometimes it's hard to kind of backtrack and get that rapport. So that's something that's important to know. A couple of red flags that you know, you may hear, you may be able to pick up on. Obviously, somebody who speaks for them, there's some component of control there. They don't know where they live. Their story seems scripted of, you know, why they may have that infection or why they may having that. Sometimes it comes out that they owe somebody a debt. They're not allowed to go alone, or maybe it took them a while before they could get to the doctor. That would be things that I would be asking a question about. A little bit on labor trafficking. We talk a lot about sex trafficking, but a little bit on labor trafficking. They may be hired for a different job. Their boss may bring them in with an injury and maybe trying to talk for them. I've had that before, and it wasn't until I separated them for the boss to go fill out paperwork that the employee did feel comfortable to kind of disclose a little bit. Sex trafficking, you know, we're going to see them. They're going to come in with clothes on that doesn't fit the season. They're going to come in with, like we've said already, malnourishment. They're going to come in with physical abuse. The other thing with sex trafficking, I'm sure they've already talked about, is tattoos. And sometimes as a provider, that's a way that I'm able to get more information. Every tattoo, if you have tattoos, every tattoo has a story. And so that sometimes is a way to start a conversation, and that could be a red flag. If it takes them a long time to tell you how they got that tattoo, if they chose that tattoo, they have a story, it's going to come to them like that. They're not going to have to try to figure something out because you caught them off guard. They didn't anticipate you asking about their tattoos. Also, if they have the same tattoo on multiple parts of their body, that's a reason to ask. So we've done the first step. We've decided how we're going to assess these people depending on how they present, or, you know, what our area sees. The second step is you got to get a specific staff member. So whether that's going to be a sexual assault nurse examiner, whether that's going to be a specialized social worker or a therapist, somebody with specific knowledge of these type of victims, these type of people, need to be assessing them, needs to be talking to them. If you get just Nurse Jane down the street who doesn't want to be at work, much less be talking to somebody who's a victim, she's not going to be the best person to adequately identify victims and provide them the best resources. Once we're interacting them, we've identified them as a victim, we've gotten the right person to them, that's when it's going to be important to make sure that we get them the right resources. The last thing that we need to kind of know is safety, and know that they did not come to us to disclose. The purpose of them coming to us was for them to get medical care and to feel safe and to make sure that their body is taken care of. So when we come back to the medical world and we realize that our top priority is to provide them the best care that we can do, to treat them, empower them, educate them, like we've said in the beginning. Realize that we're not going to save them, and that we just need to make sure that we give them the best care. Make sure that if you're really concerned about them, that they follow up, they know where to follow up at. Get them to save, your clinic number or the shelter number or the bridges number in their phone under somebody's name or under the grocery store or something like that, where they know their abuser or their trafficker isn't going to find it if they're able to have a phone. If not, give all of the information verbal so that they don't have anything that would potentially put them in an unsafe situation. You can always have them to come back in a couple of days and get them to have a follow-up. And a lot of times their traffickers will allow them to do that, because ultimately their medical health is important to them, because it gets them better work. If patients don't want your help, you got to respect their decision and know that you've provided them with the best information and resources. But at the end of the day, if they don't want to, it's fine. You just do what you do and you continue on. Documentation, that's the last piece that I'll talk about, is just make sure you don't double chart, because it could get you into trouble. So if you're going to do a medical exam, make sure that you do a lot of your charting in that document. And make sure if you do chart in your electronic record and on paper, that you try to make sure it's the exact same, because that's where we see most of it causing trouble. The last thing is, if you have a victim, make sure you know your resources. Whether it's minor, whether it's an adult, know where you can get them help. And that would be with the tower, through the Center for Violence Prevention. Thank you for your time. I think I've ran over about a minute or two. If you have any questions, my name and number will be posted, and so you'll be able to call me or email me. Thanks for your time.